Assalamu alaikum. I'm Dr. Rizwan Naeem. I'm a professor of pathology at Albert Einstein College of Medicine and Montefiore Medical Center. And I am privileged to talk to you guys today. We're going to talk about prenatal screening for genetic disorders. So let's start with what prenatal diagnosis is and why do we need it. In about 1 in 300 pregnancies, there's a recognizable chromosomal abnormality. And 95% of those are either trisomy or 3 copies of chromosome 21, 18, 13, or changes in chromosome X and Y. Most of these are Down syndrome. It happens with increasing maternal age, increases the risk of chromosomal abnormalities. So this is about chromosomal abnormalities. In addition, we also have about 1 in 33 babies born have birth defect, which is about 3% of all the babies born in the United States each year. Birth defects usually can occur at any point during pregnancy, but most of them occur during the first trimester, when the baby's organs are developing. So let's start with setting up the definition of screening versus diagnostic testing. There's a big difference between screening and a diagnostic testing. So what screening means, identification among apparently healthy individuals of those who are sufficiently at risk of a specific disorder to justify a subsequent diagnostic test or procedure. So basically what it's saying that unless you prove that people with apparently normal healthy individual, if you do justify yourself for a screening test, what it means that there is subsequent reason that they can be benefited by a diagnostic test or procedure. So one of the screening technique I'm going to talk about is called maternal serum screening test. They are made up of some biochemical markers in maternal blood. They identify chromosomal defect and they also identify open neural tube defect. So prenatal screening there are many methods of prenatal screening. One is maternal serum screening, as I mentioned. Second is visualization of a fetus. Ultrasound, for example, 2Ds and 3Ds. Very special circumstances can lead to X-rays and fetoscopy. As I mentioned, genetics and biochemical studies of fetal cells. It can be done by amniocentesis, when we draw a small amount of fluid from amniotic sac, or by chorionic villus sampling or biopsies. We can also do prenatal diagnosis by fetal blood samples, which is called percutaneous umbilical sampling at the latest stage of gestations. And the most recent method of prenatal screening, which we're going to talk also, is called circulating fetal cells in maternal blood. So prenatal screening has been around since 1948. Started with cell-free DNA was first discovered. Then prenatal screening begins with development of ultrasound. Then amniocentesis were discovered, used to identify genetic disorders. In 1780s, amniocentesis and second trimester screening become very popular. In 19, second trimester of quad screening become very popular. And now in 2011, first clinically available non-invasive prenatal testing by cell-free DNA in maternal blood has been adopted. So again, definition of prenatal screening is screening can be determined whether the baby is at more or less likely to have a certain birth defect. Many risk factors are there for the women's for having an abnormal pregnancies. For example, ethnic background of couples, family history of genetic disorders, and disorders such as Down syndrome, cystic fibrosis, Tay-Sachs disease, or sickle cell. So let's go back to screening versus diagnostic testing. Genetic screening is offered to all pregnant women and is usually discussed during the first prenatal visit. It's optional, but not required. Genetic counseling and diagnostic tests are not the same thing. Sorry, what I meant is genetic screening and diagnostic tests are not the same thing. The screening is measuring a level of risk or chance for a genetic disorder in a fetus, and diagnostic testing is a certain way of telling is this patient have a genetic condition, genetic disorder or not. So let's start with first trimester genetic screening. First trimester screening tests are usually done between the 10th and 13th week of pregnancy. We measure certain levels of maternal substances in maternal blood to assess the risk of Down syndrome and other chromosomal abnormalities. The other most important, very important test in first trimester is nuchal translucency. Uses ultrasound to examine the area of back of the fetus neck for increased fluid or thickening, which may indicate a potential risk for Down syndrome and Turner syndrome also. Combination of these two biochemical marker plus nuchal translucency can be used as a very powerful combination for the integrated screening. What we can do in second trimester, as you know, the open neural tube defects can only be identified in second trimester. There is a screening called quad screening, which uses 4 different enzymes in maternal blood to assess level of or presence or absence or risk of open neural tube defect. And of course, Down syndrome and other chromosomal abnormalities. So what are multiple marker screening? So these screenings are, this test is used for identifying Down syndrome, trisomy 13, 18, and neural tube, open neural tube defects. So maternal blood work is done in first trimester, which include AFP, HCG, UE3, and inhibin A. Then comes the quad screening, where you measure 4 different enzymes in maternal blood. So this chart just shows you that what different risk factor and testing can, what type of results these testing can achieve. So for example, if you're looking for Down syndrome, if you only look at age, you can determine about 30% of Down syndrome risk factor by age only. As age increases, risk for Down syndrome increases. We all know that trisomy 21 is the results of non-disjunction of meiotic cells. But if you measure AFP as a single marker, you will determine 37% of of cases can be assessed. And if you go to the most advanced testing, like involve all four markers, you can go, your testing reliability can go up to 76%. So let's have a question, knowing what we know for now. For example, a 30-year-old undergoes an amniocentesis because of a multiple marker screen indicated a risk for Down syndrome of 1 in 125. So you did a screening test and the risk is 1 in 125. This test, as I mentioned, is a screening test, so it has to be followed by a diagnostic test with the amniocentesis. And amniocentesis revealed that its karyotype of fetus is 45XX translocation 1421. Is this an abnormal baby? No, it's not. Because what's happening here is you have 45 chromosomes and one of the chromosome 21 is attached on chromosome 14. So the screening test just determined that this patient may be at high risk for Down syndrome, but actually this patient is this fetus is not has a Down syndrome, but now he is a carrier of a translocation which contains chromosome 21, which if this fetus, whenever will go for a pregnancy, will have a higher risk of getting a Down syndrome. So if we do a screening followed by chorionic villus sampling or biopsy, for example, you may see a 35-year-old whose CVS result indicate a mosaic trisomy 15. What mosaicism means when you have two different cell lines in one results. So 10 cells with 46XX and 20 cells with 47XX plus 15. So this is a troubled pregnancy. So now if we follow this patient with another amniocentesis and results come back on the same patient as 46XX, and the cell line with 3 copies of chromosome 15 or trisomy 15 disappeared. In these cases, we have to be careful about uniparental disomy. For example, chromosome 15, if the 2 chromosome 15 are inherited from one parent, they can either show a syndrome called Prader-Willi syndrome, or if they are from father's side, it can show as Angelman syndrome. So whenever you see this trisomy 15 cells in amniotic fluid or a disappearing trisomy 15, then there is a risk or chance for uniparental disomy, and that test need to be determined to make sure that patient is carrying chromosome 15 from the same parent. Another case study is this, that 25-year-old having amniocentesis because serum screen indicate 1 in 50 risk for trisomy 18. And the chromosome results are, again, you have 2 cell lines. One is a 47XY plus 20, and the second is 2046XY. So chromosome 20 trisomy may be, the trisomy cells may be found in kidneys, bladder, intestine, and so on. And most cases are phenotypically normal. So usually we do not worry about it. So in conclusion, many options now exist for screening pregnancies for fetal chromosome abnormalities. There is no consensus as to what is the single best screening protocol for all patients. First trimester alone is superior to second trimester screening, but is extremely operator dependent because of nuchal translucency can be determined by different people as different thickening. Then there is an integrated screening where you combine ultrasound, and 4 markers together. And then there's a sequential screening where you do first test in first trimester and second test in second trimester. So if you look at all these markers, if they can combine into, and we can keep the false positive rate at 5%. Like for false positive rate means 5% of the time your screening test may be positive, but actually patient will not be positive for that chromosomal disorder. And as you can see that first trimester screening can be positive, can be accurate, or detection rate for trisomy 20 probably is 82 to 87%. If you only use triple screening, it's 69%. If you use quad screen, it's 81%. If you integrate everything, it's 96%, with 5% false positive rate. So if at the end of this table, you see that cell-free DNA. In this type of screening, your false positive rate is only 0.5%, less than 1% or half of the 1%. And your accuracy or detection rate for trisomy is 99%. So this is a game changer, and this is becoming method of choice for prenatal screening for Down syndrome and other chromosomal abnormalities. So what is cell-free DNA and how it comes? Usually found, cell-free DNA, cell-free fetal DNA is usually found in fragment of up to 200 base pair in size. And it gets to the mother's blood through placental barrier via physiological cycle of apoptosis in the placenta, which begins with the proliferation of cytotrophoblast. So cytotrophoblast go through apoptosis and cytotrophoblast, and then they extrude into maternal blood in a small fragments. So what is non-invasive prenatal testing? As I mentioned, it started with the discovery of cell-free DNA in maternal or pregnant women in 1970s. It is used as a screening test, not a diagnostic test. It requires a certain amount of fetal DNA relative to mother's DNA. This is known as fetal fraction, and usually about 4% is required. So 4% of total DNA in maternal sample has to be fetal sample to make it work. And at about 10 weeks of gestation, that's where you can find it. It's used to detect trisomy 21, 18, 13, X and Y chromosome copy numbers, and more tests are being developed. These are the different cell types which you see in maternal blood. Nucleated red blood cells are about 10% of the fetal RBCs are nucleated at 11-week gestation. As pregnancy evolves, the RBCs or nucleated RBCs go down. Fetal DNA in maternal circulation is present throughout the pregnancy, useful for detection of a single cell disorder not present in mother, for example, achondroplasia. What is non-invasive prenatal testing? The principle is that the fetus with an aneuploidy will have higher or lower amount of abnormal chromosome present in maternal plasma sample. If you do massive parallel sequencing, or we call it NGS, next-gen sequencing of millions of pieces of DNA molecule from maternal plasma and then aligning them with the sequence back of its chromosome of origin. The proportional representation of each chromosome in maternal plasma is determined. To determine the aneuploidies, the proportional representation can be compared with a group of healthy pregnant women carrying euploid fetus. Basically, you are sequencing a large amount of small DNA segments and measuring the quantity of each chromosome. And if fractionation, if there is a higher fraction of trisomic cell or lower fraction of monosomic cell. There is another technique called SNP-based technology, which uses a SNP across chromosomal region of interest followed by sequencing of amplicons. So if you look at NIPT statistics, so the overall positive rate of trisomy 21 is almost 99.6% sensitivity and 99.9% specificity. Trisomy 18 is 99% and 99.89%. Trisomy 13, 98.9% and 99.9%. Because of NIPT, we are now doing less procedures for amniocentesis and CVS, which has decreased the number of miscarriages as a byproduct of, which is a byproduct of invasive testing. So whenever pregnant woman goes through amniocentesis or CVS, there is a slight increased risk for losing that pregnancy. This has also decreased the number of miscarriages in pregnant women. Sometimes there is a less DNA, less fetal DNA in the test. So in those cases, we ask patient to do another redraw, and in most of the cases, those results are obtained by redraw. So in recent advances, we have started seeing some syndromic testing also by NIPT or non-invasive prenatal testing. As you may know, DiGeorge syndrome is the most common deletion and duplication syndrome in human, and it is found in about 1 in 3,000 to 6,000 live birth, and has a very varied, different clinical presentation. So by using SNP-based testing, we are able to, about 87% of all these cases can be determined or detected by prenatal screening of fetal cells in maternal blood by non-invasive prenatal testing or NIPT. So cost for NIPT in US, this is not relevant to Pakistan, so I'm going to skip this slide. What are the benefits of non-invasive prenatal testing? Fewer women have to having diagnostic tests with the associated risk of pregnancy loss, as I mentioned, because if the test is 99.9% sensitive with 99 point something percent specificity, you don't need to do a diagnostic test. Increase access to patients. Many patients are afraid of going through amniocentesis and CVS sampling. Early test results, for example, test can be determined in 9 to 10 weeks of pregnancy when patient is not very pregnant looking, and then patient can make a decision for continuing or not continuing with the pregnancy. There is no risk of miscarriage as there is no procedure involved. This testing is done by drawing maternal blood and nothing to do with no manipulation of fetus fluid or CVS. It detects the most common chromosomal aneuploidies. It has a higher detection rate and lower false positive rates than any of the maternal serum or integrated testing. But there comes the limitations of NIPT also. If there is a mosaicism in pregnancy, or it's a post-zygotic mosaicism, most of the time NIPT will not determine that, which is present in about 1 to 2% of coronavirus sampling. Confined placental mosaicism is another problem which NIPT cannot resolve. Sometimes there is a mosaicism in placental side and not in fetal side, and vice versa. Thus, in these cases, there is a very slight risk of false positive by NIPT. So just to revisit again, NIPT cannot detect chromosomal differences other than aneuploidy of chromosome 13, 18, 21, X and Y. Some companies are now adding screening for other trisomies, certain microdeletion syndrome also. They can also determine single gene conditions or disorders. Detect congenital, it will not detect congenital anomalies. All about, in combined cases, about 6% of the time, there is no result or quantity not sufficient type of results. It is not useful test for twins and IVF pregnancies. With that, I'm going to end, and that will be my last slide of showing that if you look at everything together, you can see that NIPT or non-invasive prenatal testing is probably the most advanced and satisfying and valuable genetic test for prenatal screening. And false positive rate is less than 1%, and detection rate and sensitivity for almost 99%. Thank you so much.